something brief on diabetes, the types of diabetes that we have, the pathophysiology, a brush on that, the risk factors, signs and symptoms, complications, but I'll dwell more on the medical management and the medical nutrition therapy and some of the barriers and enhancers to adherence to MNT, the questions that we've been asking ourselves, whether our patients really appreciate what we do and why sometimes our review numbers are lower than the first cases or the new cases that we see. Okay, so in terms of what diabetes is, all that we know is a chronic disease. It's type 2 diabetes that now we know patients can be sent into remission. Therefore, they don't need any medication. They are just using lifestyle factors to control their sugar. Some have said that this remission is just a delay to the onset of proper diabetes diagnosis. Others also have seen, other studies have also seen patients who have been on remission for many years, decades, and they are still not on any medication. And it is characterized by hyperglycemia, which we know affects both micro and macrovascular vessels in the body. And its impact on food for energy. Diabetes, as we know, it's compared to hypertension, someone who is hypertensive can move anywhere and fast and do many things in relation to diet and not have any complications. But for someone to be diagnosed diabetic, food and energy is something that they can't do without. And it's controlled by the insulin secretion and or inaction. So as we go on with the types, we will understand why the secretion and or inaction. So just a brief, I think we are in the clinical, most of us are in the clinical setting, so we know how the numbers are increasing and the varying age ranges that we are seeing. But in the world, as at 2021, 537 million people live with diabetes, and 3 in 4 adults live in low-income countries or middle-income countries, of which Ghana is part. Then type 2 diabetes accounts for over 90% of diabetes diagnosis worldwide. In Africa, 1 in 22 adults live with diabetes. So as we go to church, as we go to functions, if you are to count 22 people, you get 1 person being a diabetic. And the total number is estimated to increase by 129% by 2045. And in terms of death in 2021, diabetes alone contributed 416,000 to the global total death. In Ghana, as of 2021, it was estimated that the prevalent rate was 2.6%. No, the prevalence was 2.6%, and that represented 329,200 people. And this number is estimated to increase to 3.13 in 2045. So in terms of the types, there are many other types, but the major ones that we see at the clinic are the type 1 diabetes, type 2, and the gestational diabetes mellitus. And with the type 1, we know that the body does not generate insulin for glucose regulation, whilst the type 2, there is insufficient insulin, or the action, the work of the insulin is impaired. Whilst in terms of gestational diabetes, the body is not able to produce insulin for glucose regulation. And I will give you some of the reasons behind this issue in pregnancy. For type 1, before I continue, please, I want to give credit to some of our interns at the diet therapy unit in Confanoche, Anastasia and Phyllis. Our in-house presentation, I took some of the slides from them, so I am giving them credit for their work. Type 1 diabetes. We know that it's autoimmune reaction, and the it leads to beta cell destruction, usually leading to absolute insulin deficiency. And it's immune-mediated idiopathic. Some of them, we don't really know what causes it, just that the body has set off its own reaction. And the end result of beta cell destruction disqualifies the patient to take any oral medication and is placed straightforward to insulin injectables. With the type 2, it's characterized by beta cell dysfunction, it's increased pancreatic alpha cell function, then peripheral tissue insulin insensitivity. And for this, we know that hyperglycemia due to impaired peripheral glucose uptake, that is related to type 2 diabetes. There is also the presence of this lipidemia, where we have hypertriglyceridemia and low high density lipoprotein. This is due to impaired peripheral fat uptake. We know that with type 2 diabetes and in general with diabetes, the patient will eat, but the cells and the tissues will not have access to the nutrients or the glucose because of that barrier in insulin work. So the patient has to depend on their fat stores to make gluconeogenesis and protein stores, and that leads to hypertriglyceridemia and low HDL levels. There's also impaired amino acid uptake and ATP production into peripheral tissues, such as the skeletal muscle, due to the impaired nutrient uptake, as I just described. Then there is also increased glucagon production, which further amplifies hyperglycemia and hyperlipidemia. So basically, we have the pancreas, which is involved. We have the gut, we have the liver, we have the muscles, and the adipocytes. And with the pancreas, when there is reduced insulin secretion, it leads to increased beta cell apoptosis, that's the cell death. Then there's decreased beta cell mass, their numbers reduce, and this leads to hyperglucogonemia. And with the gut, when there is impaired incretin effect, and now we have medications that are targeting incretin specifically. The liver, where there is insulin resistance, we have increased hepatic glucose output. With the muscle, there is insulin resistance, so it won't take up any insulin, and so the body has to depend on its own muscle to survive. For the adipocytes, when there is increased circulating fatty acids, and that's what type 2 diabetes will cause, and this leads to hyperlipidemia. We know that obesity, I'm still talking about the adipocytes, obesity increases or is also associated with increased cytokines and fatty acids, and this further leads to insulin resistance. So let's look at the risk factors. We all know about the modifiable and the non-modifiable risk factors, where the modifiable factors, things that we can do something about, the non-modifiable factors, things you can't do jack about. So the physical activity, the body fat and weight, the high blood pressure, the cholesterol, those we can do something about with our lifestyle. But the gestational diabetes, I can't delete my pregnancy. So it's not something I can really negotiate. So that is a non-modifiable factor. I am not causing the sugar to rise whilst I'm pregnant. The race or ethnicity, we have the age over 45. Some studies also say that 35 years, then the family history of diabetes. In terms of the category, we have the risk factors that are low, medium, and high. For someone to be less 25 years of age, and no previous history of poor obstetric outcomes. That means the person didn't have any high blood sugar during pregnancy or high blood pressure or any kidney issue. Then part of a low-risk ethnic group, no DM in first-degree relatives, their immediate father, mother, and siblings, normal pregnancy weight and weight gain throughout pregnancy, and no history of glucose intolerance. The medium one, when the person does not fall into low or high risk categories. For the high risk, if the person is obese, DM in first degree relative, and has current glucosuria, that is sugar glucose in the urine, history of gestational diabetes or glucose intolerance, then previous delivery of infants with macrosomia, that is large baby weight or increased baby weight. And we have the environmental risk factors, we have the socioeconomic risk factors. And with this, we will understand at the latter part of this presentation how it presents as a risk factor in terms of education and income. Individual risk factors, which we've seen, the ethnicity, genetics, and prenatal exposures, dietary patterns, inflammation, and adiposity. And with the inflammation, we know diabetes is basically is predisposed and the long-term complications. It is known that someone who is diagnosed as gestational diabetic is likely to be diagnosed proper diabetes patient in the next 5 to 10 years after delivery, if all factors remain the same in terms of the lifestyle factors that we just mentioned. So let's look at the symptoms of type 1 diabetes. I'm rushing through because this is something that we use in education and it's not something I have to use more time on. So we have the visual impairment. As I said, diabetes affects both macro and microvascular tissues and organs. So wherever blood is passing, it will enter and destroy that place. A constant feeling of hunger because the peripheral tissues are starving whilst there's a lot of sugar in the bloodstream. Unexplained weight loss because of that, frequent infection of the genitourinary system and skin, because I know some people just taking sugar exposes their genitalia to infection. So they start itching as soon as they take sugar. So someone with high blood sugar is always going to have issues with UTI. Frequent urination, dry mouth, nausea, vomiting, abdominal pain, and strong thirst that you can't do anything about. I got a patient who takes about 4 1.5 ml bottles of water in the night before he wakes up. And that was before he came to see me. For type 2, we have itching, strong thirst, dry mouth, visual impairment, numbness and cramps in legs, frequent skin infections, frequent urination, slow healing of wounds, a constant feeling of hunger and weakness. So just the itchiness should also draw your mind to direct the person to go and test. With the gestational diabetes, we know is a vicious cycle. Apart from the mother being at risk of being diagnosed diabetic in 5 to 10 years, the child that she is carrying whilst diagnosed with gestational diabetes is also at a higher risk of being obese, because most of these babies also are macrosomia babies. Then they are also at a higher risk of being diagnosed diabetic in their adult years. So that vicious cycle starts with the mother, then the baby continues, and it goes on like that. Then let's come to the medical management. With this, we just want to know so that if our patients are on them, we know what that medication is doing in their body. We have the sulfonylureas, and one example is the glimepiride, and is known to stimulate insulin secretion from beta cells. So that is where we know, although the beta cell mass has reduced, there is still some that can be ignited to do their work. Then we have the thiazolidine. I always twist my tongue, but you can see them. So an example is pioglitazone, and it's also known to improve insulin sensitivity. So that means the insulin level is there. It's just going to improve its sensitivity, or the peripheral, the tissues and the other cells, how sensitive they are to insulin. Then we have the SGLT2, and one example, this is a current drug that is now being used, and it's in Ghana, Forxiga. It's known to stimulate the excretion of glucose through the urine. We just talked about UTI. We know hyperglycemia already increases the sugar in the urine, which predisposes the person to UTI. So if we have a medication that is contributing to more glucose passing through the urine, then as dietitians and nutrition professionals, we are supposed to also think ahead. Am I going to give the person some probiotics or prebiotics to help regulate the microbiome in the private part, or in the vagina, or wherever in the reproductive organ? This is something that we have to consider. So if the patient is on this, you have to advise as such. Then the biogonite example is the metformin, which is the usual one. It's supposed to decrease hepatic glucose production. And we know with metformin, it leads to increased weight or weight gain because there is more absorption of fluid. So when a patient comes, they are now increased in weight. Let's look at their medication and see if there's metformin. Then we can look at their diet and see whether we can massage it a little to not contribute so much to the weight gain, which we know can also worsen the whole situation. Then we have the GLP-1, and this example is supposed to stimulate glucose digestion in the gut. So instead of it passing, some being digested in the gut before it leaves, this is to enhance more digestion of glucose in the gut to help better absorption. And now we have the middle one, vitamin C and D. In the consulting room, we see some patients coming with vitamin D drink, and some being given Zincovit. We know Zincovit, with the zinc in it, studies have shown that helps with blood sugar control because it helps with sensitivity at the beta cell level. The vitamin D is given not to everyone, but to patients who are predisposed to osteoarthritis, because we know there is a linkage of diabetes with calcium, and the aging to, if enough vitamin D is not consumed, the person will lose more calcium, especially from the bone. So this is given as a prophylactic measure to prevent further further loss of calcium from the skeletal muscle and the other side for calcium storage. And we've also heard from other presentations the impact of vitamin D on hypertension control or blood pressure control. So, and we know one of the risk factors for diabetes is also being diagnosed with high blood pressure. So if a patient is given vitamin D, we know if the blood pressure is controlled, the sugar too can be well controlled, possibly. Now, let's go to the goals of MNT for diabetes in general. For every nutrition prescription that we make, it should be based first on the metabolic profiles. So whatever biochemistry the person comes with, whatever we plan should be based on that. Then it should be based on the treatment goals as I said, the medical management that the patient has been put on and what we will be recommending, then the willingness and ability of patient to make the changes. This is the subjective part that we mostly don't look at, especially when we are fresh from school. It's like we've learned it, so go and do this, go and do that. The patient will listen, but as soon as they go out, that is it, and they will never come back for second or third review. So we also have to plan our MNT based on the willingness and how principled and determined the patient is to the changes that we are recommending. And it should be built on the role of lifestyle in improving, one, glucose control, lipid and lipoprotein profiles, then the blood pressure. And this can be done through the food choices and physical activity. It's known to help reduce the risk of diabetes and cardiovascular diseases. Food choices and physical activity has to be considered, and this is to lead to weight loss, which will be maintained, not the ones that will clap for you in the month or two, the person gains the weight back and is discouraged because all the measures they took to bring the weight down, it has increased again. So what are the goals of MNT? One is to achieve and maintain blood glucose, lipid, and blood pressure levels to normal range or close to normal range as safely as possible. So with these three, the blood sugar, the blood glucose, the lipid, and the blood pressure, that is our first goal, to make sure it is within the normal range in a safe way. Because if a patient comes with blood sugar 18, and the next time they are coming and it's about 3.5, you are very sure that either the medical treatment is overdosed, or you did so much over restriction that the patient got so hungry and now the sugar is getting to hypoglycemic levels. Then to prevent or slow the rate of chronic complications of diabetes. And we know the complications, the neuropathy, the retinopathy, and all the vascular and cardiovascular conditions that diabetes comes with. And diabetes is a progressive condition. So if we are able to prevent or even slow progression, the person can live with a quality of life up to the level or the years that God destined them to have. And to address individual nutrition needs, considering their personal, cultural, and willingness to change, it has come here again. So whatever you are planning, it should be based on the individual's own personal, their culture. So if the person tells you, I don't know how to eat fruit, I've never eaten fruit before, how are you going to start the patient with, so that at the end of the day, they will love eating fruit without pressurizing them and making them willing in their own way to make those changes? The cultural changes, whatever we do in Accra, you can't come and do in Kumasi. It won't be sustainable. And whatever we do in Kumasi, if we come to Accra, they'll tell us we are not serious because you're always busy and always rushing around. So we have to look at the environment, the cultural factors that have effects on nutrition. Then we have to limit the food choices based on evidence. So if you've heard about 1,005 kilocal, so any diabetic patient who comes is about 1,005, irrespective of the dietary history that you have taken. And whatever you are recommending, although we are marrying the evidence from literature, we also want to maintain the pleasure of the patient in eating. And we say it's a chronic condition. If you are to find yourself in that category for many years, more than 20, 30 years, depending on when you were diagnosed, if you have to go through this regimen, it's very strict, very soon you just say, oh, die be die. And you do whatever you want because you can't stress yourself. You are working and you need to enjoy the fruits of your labor. So the goals of MNT that will apply to specific situations. in terms of the youth, the neonatal, and whatever that does not fall under the category that I meant, the 3 categories. The main thing is just to meet their nutritional requirements for all the life cycle. So if the person is a youth, a teenager, a pregnant woman, as we've already mentioned, the person falls within the geriatric range. We look at all the factors. Example, geriatrics, their taste buds is not as sensitive as when they were young. So when you are giving food, you make sure that you make it as sumptuous as possible and let them understand why you are making, maybe you are reducing some things they wanted you to, like salt, for instance. So when they understand it, it helps, and how to really make the food tasty to meet their taste buds as they are used to. So that's something that we have to consider. With patients with insulin-dependent diabetes, we just have to teach them on self-management in relation to exercise and how to prevent and manage hypoglycemia. And it's also a goal for MNT to give them an idea, educate them on the treatment of acute illness, what can be done. Okay, so with the insulin regimen, for type 1 diabetes, we are supposed to integrate the insulin regimen into their usual eating habits and physical activity. In Ghana, we don't have much privilege, but the first one I want to talk about is the physiologic insulin regimen, which an example is the insulin infusion pump. This is somehow designed or made to mimic the natural insulin secretion in the body. So as we see in the picture at the top right corner, that is the pump there. As the person just enters the dosage there, and the machine will just give the insulin based on the calorie level or the carbohydrate content of the meal the person is about to eat or has eaten. So the person is able to eat the ice cream and all the other food as any normal, in quotes, any normal person without diabetes will take. So, and that is based on daily or hourly or whatever intake the person is taking. The fixed insulin regimen, this one is prefixed, and that's the down one. That's what we have in Ghana. I know some people travel and come with the pump in Ghana, but it's not that common. So the fixed insulin regimen are the ones that we have. With the physiologic insulin regimen, it allows for increased flexibility in choosing when and what to eat. Compared to the fixed one, if I give myself in the morning, I have to eat my food. By evening, as soon as I give it, or after, my food should be ready. And this is not to be said for the physiologic insulin regimen. And you are able to adjust mealtime insulin doses based on the carbohydrate content of your meal. So it's not strict that it's 1,005. So sometimes in a celebratory mood, the person can go 3,000 and just plan or adjust the dosage to meet the amount of carbohydrates or content in the meal. With the fixed one, that is why we do what we do. I know when we find ourselves elsewhere, we can also plan for the person to eat according to the pump they are given. But in our setting, we have to do a day-to-day consistent timing and amount of carbohydrates. So if I give 1,005, I know the person is taking this and this dosage of insulin. And we know 1 unit of insulin is to clear 15 grams of carbohydrates. So I calculate French, very strict one, so that it will better control the sugar of this person. With the type 2, the main things that we look at with the MNT is to adopt lifestyle intervention to improve metabolic abnormalities. So in cases where we have lipid issues, high blood pressures, and the other, maybe there's obesity and its related complications, it's to help improve them. It's also to reduce energy intake and increase energy expenditure. So we include always physical activity to help regulate the blood sugar, as we are also calculating how much energy they are taking. It's also to limit intake of saturated fat, trans fatty acids, cholesterol, and sodium, which we know are all linked to these three metabolic conditions we mentioned: high blood pressure, dyslipidemia, and high blood sugar. Then the blood glucose control, improved food choices, increased physical activity, and moderate energy restriction. So as soon as you do intensive energy restriction, you will come to some of the things that patients have said in a study. The physical activity is known to improve insulin sensitivity and cardiovascular status, and it's also known to acutely lower blood glucose. We are also to educate on types and sources of carbohydrates, average portion sizes, and number of servings per meal. So if I'm giving 1,005, I know this and so this so amount, maybe 3 servings of carbohydrates for morning, this amount in the afternoon, this amount in the evening, and the patient is well educated to understand that. So in pregnancy, our goal is to achieve and maintain optimal glucose control, because we know any highs in blood sugar will increase the body weight of the baby, and that will lead to complications or obstetric complications during childbirth, or it can even lead to the death of the fetus. It provides adequate maternal and fetal nutrition throughout the pregnancy. That is our goal in terms of gestational diabetes. So whilst we are meeting the mother's need, we are also meeting the fetus need to help both of them grow in optimum levels. Then energy intake should be appropriate in relation to maternal weight. And this is, in pregnancy, we expect them to increase weight, but the weight should be within the normal range. And our goal with the MNT is to help them achieve that. Then to provide necessary vitamins and minerals that will help, as I said, with the vitamin C and D. If we are gaining some from the diet, it will always help to regulate the blood sugar. And pregnant women too are to be given small meals and frequent snacks. With the small meals, this is not in relation to the beginning. Maybe the first trimester, most of them have gut complications like nausea, vomiting. If that is there, the small frequent meals and snacks still stand. But if those reactions are not there, eating a proper, healthy, enough calorie for breakfast, lunch, supper is okay. But the third trimester, when the baby size increases, you realize that the mother is not able to eat a lot. So I eat right now, and in the next 1 hour, 45 minutes, I'm hungry again. And also that depends on the content of the meal, but mostly they feel hungry. So we give frequent snacks, even in addition to bedtime snacks as well. And to educate on types and sources of carbohydrates, average portion sizes, and number of serving sizes per meal. So we know the MNT is documented, or we implement it using the nutrition care process. So with the nutritional assessment, we look at the anthropometrics, and we are not just looking at BMI. Let's go further with the waist circumference, waist to hip ratio. If we have access to body composition analyzers, let's utilize them to get detailed information in relation to their anthropometrics that will inform our planning for them in relation to the calorie and total energy that will be given. The diabetes history If the person has any family member with diabetes, then you know that there is a strong genetic predisposition. Then food and nutrition history, does the person have any intolerance? Does the person have any allergies in relation to food? Does the person have some likes and dislikes? It's not really an intolerance, but I just don't like it. We just have to document all those to help us during the planning stage. The social history, since income and occupation have effects on the implementation of MNT, getting that information helps and will help to direct your planning and your counseling or education to help the patient understand and work with the recommendation. The medications, as I've already outlined, it also gives or has impact on whatever recommendation you have. Then the knowledge base is also something that we have to consider. In terms of the knowledge base, it's about what does the person know already? How willing is the person ready to make changes in their lifestyle? That is nutrition related. That's the knowledge base aspect. Then we have the nutrition diagnosis, where we have the problem, etiology, signs and symptoms. This is necessary because after implementing your intervention, this is one of the things that we are going to use to assess ourselves and assess the patient, whether we've been able to achieve our goal. So the problem is a nutritional problem, either inadequate fiber intake, inadequate calorie intake, excessive calorie intake, excessive carbohydrate intake. Whatever the nutritional problem is, we state it as such. The etiology, most of us, we are always talking about food and nutrition knowledge deficit. That is one example. And there are other etiological examples that we can use in our PES, the signs and symptoms. The ones that we observe ourselves, like if there's pedal edema, if there are skin rashes, if there are some cysts on the skin, these are things that we have to write down so that when the patient comes for review and you assess and you see that these signs are no more there, then you know that the MNT is also contributing something to the health of the person. The symptoms are what the patient will tell you. In terms of the intervention, there are two stages, the planning stage and the implementation stage. So with the planning stage, it is done in sync with the patient or with the person who has been diagnosed and referred to you. So we don't sit in our corner and plan, this is what I've planned for you, this is what you are supposed to eat. It is supposed to be done in connection, in partnership with the patient who is going to implement it. And with the implementation stage, we tell them, we give ourselves timelines, we give ourselves schedules, we give ourselves the timing of meals and all the others, so that everybody, you are clear, the patient is clear, and they will be able to implement the recommendation that you are giving. With the nutritional monitoring and evaluation, we have to identify a plan. So with all the nutritional assessment, diagnosis, and the intervention, what is your plan? What are you looking out for? And within what time? That's when you create your timelines. And you monitor medical and clinical outcomes. So with the blood sugar control, it's known that between 6 to 8 weeks, you should see a real reduction. Although most times we see it before even the 6th, within 4 weeks, we are able to see differences. But you monitor that and link it to your recommendations. Then you write, we have to get progress notes. Those of us who have the softwares in our hospitals, we're able to write how the patient is progressing, if they've relapsed, what has been done and what needs to be done. These are things that we have to write so that if someone else, and the reason for the nutrition care process is to help the others, someone who has been seen in Kolebu or Tafo, I can also see the person in Konfanoche. Without any break, there will be continuity with the care. So some of the factors that have been noted by research to influence glycemic response to food. So it's not just by you talking. Let's look at these factors. The cooking and food processing. So on a facial value, a food item, you brush it off that it can increase blood sugar. But assuming that food was fried in relation compared to food that is boiled, there will be a difference in how the body digests and metabolizes them. So we have to look at the cooking and food processing methods. The nature of the starch. Is it amylose, amylopectin, or resistant starch? These are all things that we have to look at. So not just is there fiber in it, but what type of starch is the food that the patient is saying he or she likes or I am recommending. Then the type of sugar. In terms of the type of sugar, is it glucose? Is it fructose? Is it sucrose? If it is glucose, we know that one is the end point. But if it is sucrose, we know it's a combination of fructose and glucose. So that means its absorption is different from glucose. And that is what we have to look at. If the person is taking honey is basically made of more of fructose and a little glucose. So these are things that we have to consider and we know influence glycemic response to food. The amount of carbohydrates. So even if I'm giving fiber-rich food and it is in the Ghanaian typical quantity, it is still, it will still have effects on blood sugar. It's possible it might increase the blood sugar level more than what we expect. The other factor that we also have to look at is the severity of the glucose intolerance. So you think that you've done a good job, but maybe the beta cell mass has been severely reduced. So how the person will respond to your guideline will be different from someone, maybe comparing someone with a beta cell mass of maybe 500 to someone who has beta cell mass of about 2000. They will all have different responses to the glucose that will be present in their meals. Then the particle size and the food form. So a food that has been finely milled, even if there is a fiber or no fiber, compared to a food that is chunky. You know, the way, like rice, for instance, most people, they don't even chew it, they swallow. And that also has effect on the glycemic response to these foods. Then we also have to consider the fasting and the preprandial glucose concentration. So assuming you've given a very healthy, well-balanced, nutrient-rich meal, and you expect that after 2 hours, the meal should have positive effect on the impact on the blood sugar, and it's still high. We don't have to beat ourselves, because whatever we are getting after 2 hours is also dependent on before the person even eats, the fasting state, the level of the sugar in the blood. And these are all factors that are known to influence the glycemic response to food. And these are factors that we have to consider when we are implementing the MNT. The first one is the type of food. So with the type of food, we will go into the carbohydrate, the macronutrient, the protein, the fats, the micronutrients, the vitamins and the minerals. And we also go into the fiber-rich ones or the complex ones, which we know are better placed to regulate blood sugar compared to the refined ones. Then the timing of meals, especially, as I said, with the fixed insulin dose patients with type 1 diabetes. If we don't look at the timing very well, they will end up having high blood sugar always, or low blood sugar or hypoglycemia, because the timing was not right. Even with the type 2 diabetics or patients with type 2 diabetes, timing also contributes a lot, because if the timing is not right, or the patient waits to be hungry before they eat, the likelihood for them to increase their meal quantity is higher compared to when they are not hungry hungry and they are eating based on time that we have given. But let's also know that these are all individual based, and we work with the patient as much as possible. Then the quantity of the meal, as I just mentioned, you can have a bowl full of salad or the vegetable, freshly cut vegetable, but the quantity the person is eating might have different effect on the body. So it's all about the proportions of the macronutrients and the micronutrients and its impact that we expect to see. Then variety, and this is seriously linked with quality of life. If the meal is one way, which we know meal patterns like the blood group diet, it restricts the variety that the patient has access to as meal. Variety works a lot to increase appetite and for the patient to really enjoy their meal. If the food is all about, in fact, with our porridges, for instance, we can count in Ghana the typical local porridges. In addition to oat, which is not local, we can count more than 7 different types of options that we can recommend to patients. And patients who also want to eat their fufu in the morning and their porridges in the evening. These are all varieties that we can bring into our recommendations with the MNT. So with the energy requirements, patients with diabetes, theirs is not different from that of the general public who are not diabetics. So it's just to meet their daily nutrition needs since they are also alive. So with the carbohydrates, we expect between 45 to 65% of the total calorie to come from carbohydrates. So the range is, if the person is obese, we can go to the lower range based on the dietary history that you have taken. So it's not just in fancy we say abostream is like, okay, I think this patient will need this, that's all. It should be based on the documents or the evidence that you have gotten from that patient. With the protein is 10% to 35%. And the 10%, it can go with maybe a patient comes before you and the creatinine, the renal function tests have started to be deranged, and we go to the lower side. We won't restrict below their normal daily nutrition requirements for protein. So these are the factors that inform how much protein should be given. With the fat and oils, 20 to 35%. Most of our patients, before they come, they would have said that to impress you, and some of us, we will commend them for doing that because we are only concentrating on the vegetables, but we know that within the vegetables, we also have fat-soluble vitamins that need the oils to be to help them be well absorbed. So we regulate how much they use it, but we don't restrict fat and oils. Even with patients with fat liver diseases or with liver factors that are deranged, we don't totally restrict fat and oils, and the type and the quality of the oil also comes in. With the carbohydrates, there is nothing like ketogenic diets and diabetes. They will really go into diabetes ketoacidosis. So we are not supposed to recommend less than 130 grams of carbohydrates a day for diabetes. So their carbohydrates can be 130 and more. And as I will repeat this should be based on the dietary history, or the patient will be afraid of you and will never come back again. You see the patients at the ward with different complications. Then we are also supposed to use carbohydrate counting, exchanges, and experience-based estimation. So with the counting, we know this is how much calories. Exchanges, okay, if you want to add sugar to your meal and I'm giving you 3 servings of porridge, maybe I can reduce it to 2.5 or 3, depending on how much sugar we are adding, so that the quality of life of the patient will be maintained, and the person can continue to follow the guidelines that we are giving. Then the experience-based estimation. Sometimes for me, my new cases, I rarely give them food models, depending on the severity of what I am seeing. I rarely give them food models as quantities that they should look at to go and implement. I rather start them on proportion size. And with that, I have seen that they are willing to follow that. In terms of proportion, I just tell them, okay, with this, your previous intake, as I have estimated from the dietary history, can you reduce it by 1/3 or 1/4? Some people, as soon as you say 1/3, hey, then you know that if you bring the food models, the person will not follow it. Then you go, okay, for this month, let's try 1/4 of your previous carbohydrate intake. Take that one out. And let's bear in mind, any reduction in carbohydrate intake has beneficial effect on the glucose and the glycated levels. So these are the things that we have to consider in relation to carbohydrates. Then the fiber, mostly the requirement is 25 to 28. Some studies have shown that there is not much difference. The higher you go, the better your glucose level. But it is recommended that between 30 to 50 grams of fiber in a meal for a client is enough to help them control their blood sugar. Then I think on our page, we've discussed a lot about sweetness, the impact that sweetness have. For those of us who know a little, I don't know much about, but those of you who know a little about the microbiome, we know that some sweetness have direct impact on the microbiome. And there are some microbiome, that is the microbes in the beneficial microbes in the intestinal walls. Some of them are specific to management of diabetes or glucose. So if these sweetness are going in to either reduce their mass or reduce their ability to do their work. So that is one thing that we have to look at. The other thing too is the senses. We know that as soon as the tongue tastes the sweetness, it sends signals to the brain that sugar has come. So set the ball rolling. So every day it sets the ball rolling, and there is no sugar, especially if we do the artificial ones. There's virtually no sugar. One calorie, there's nothing, and you keep sending it like that. You keep sending the signals and it goes, there is nothing. Very soon it becomes another issue, pathology at hand. So these are some of the factors. The other factor that research has also shown, these sweetness, especially the artificial ones, they are more of chemical based, and it is known that diabetes has effect on the kidney. And if there is anything artificial, it is the work of the kidney to help eliminate it from the system. So if we are further giving artificial stuff just for the person to have much taste of the sugar and reduce the guilt in their mind that I'm not supposed to eat sugar and I'm eating, so it clears that guilt, we are further compounding their issue. So that's why if the person cannot start with taking out sugar, and some studies have shown that taking sugar outright, the impact is not significant on the blood sugar. That is depending on the amount of sugar the person adds to their meal. That is any sugar less than 6 grams in a meal. It doesn't have much impact on the blood sugar that is raising it. So if the person can, some people by the time they can, that person is a candidate to continue with what they are doing. But if someone comes, and you know that with that variety is attacked, so what can I do to bring the porridges back? Then we do the exchanges, then experience-based estimations. With the protein, We have the animal and the plant proteins. It is known that protein increases insulin response without increasing the concentration. So we can't use protein to control hypoglycemia. So although it is increasing the insulin response, it will not commensurate with insulin concentration in the blood. So someone who is going to hypo, we can't give the person a protein bar unless there is a lot of sugar in it. That one will work. So for proper blood sugar control, it's known that protein greater than 20% of energy can be recommended. And it's known to improve appetite, it's known to improve satiety. If the appetite, whether it's animal protein, it is plant protein, or whichever type of protein, for which I will come to the plant protein. With the DASH diet, as we've known from current research, to have more impact on cardiovascular issues and non-communicable diseases, they recommend nuts. And that nut is basically tree nuts compared to our groundnuts. The tree nuts we know are the cashew nuts, the almonds, the walnuts, pecans, and the pistachios. They are known to be connected with the DASH diet. Although we know groundnut also has impact on our nutritional profile, making our food nutrient dense. So we can include these nuts. It can be an alternative. If the patient is economically okay, we can recommend the cashew, especially the unsalted one, so that we don't compound their issue with blood pressure. So they can use the cashew nut alternatively with either groundnuts or with their normal milk. And we also restrict to low fat or normal fat based on the quantity of milk they are adding. Assuming the entire family is taking a whole can of evaporated milk and they are about 6, you don't need to restrict that, go for carnation, because the amount they are adding is not that much to contribute so much to their dietary cholesterol. So this is something that we have to look at. In terms of the animal protein, we've heard a lot about eggs. Diabetes can use, but also it has been indicated that is linked in diabetes, it is linked to they having high blood cholesterol, but minimum of 1 or 2 is enough, and it doesn't have that significant impact. So egg can be used in managing with patients with diabetes. Then we also know the fishes, the different types of fishes, and they are high in omega-3. And as well as omega-6, which is known to be good, but omega-6 is more of pro-inflammatory nutrient or oil. So as omega-3 is anti-inflammatory, omega-6 is more of pro-inflammatory. So we have to balance it in a way to help the patient. We know of the offals where we have more of the visceral fat, so it can be reduced as much as possible. But sometimes if the patient likes liver, for instance, we say once in a while, and it is linked to once a month as we recommend for all red meats. With the total fat, the energy is supposed to be 25 to 35% of the total calorie. Saturated fat content should be less than 10%. Then the trans fat acid should be minimized or eliminated. So we have patients coming to us, oh, media cream crackers and one me bag me ya we anemedi me turbo fruit and no dry and yes, but we know that commercially fried foods and commercially processed foods, they are always high in trans fat. And let's not just even think about the commercial ones, even in the house, how they use their oils. Most of them, they keep reusing the same oil for a long time, and they use the rest to make shito because they've put it in their mind that oil is very expensive, so they can't throw oil away. So that's something that we have to let them know, that being sick is more expensive than the oil that they will buy. In terms of micronutrients, we look at the fruits and vegetables. With that, the patients may benefit from supplementation, but let's look at the category of patients who can benefit from these supplementations. Patients with poor diet, they don't have the appetite, they have extreme calorie restricted diet, they have subjected themselves to it, you didn't do it. So such patients, they already have deficiencies and they will benefit from calorie restrictions, from supplementation. Then strict vegetarians, those who are not doing anything animal or animal protein, those are the people who will also benefit from supplementation. If you are not sure, you can contact your physician to help you, as it's a teamwork. Then older adults, as I said, they keep losing calcium from their skeletal muscle and their bones, and supplementation is known to help since there's already a deficiency. Although even with the supplementation in this category of people, absorption is also impaired. Then we have the pregnant and lactating women. For them, more of folic acid supplementation. We know it's known to help with preventing neural birth defects. The medications known to alter macronutrient metabolism, as we looked at all the classes of medications given. If there is one that is specific to reducing specific nutrients, then we can add the supplement to it to help balance the level of those nutrients in the bloodstream of the person. Then patients in poor metabolic control, they have hyperglycemia with a lot of urinating with sugar in the urine. Those people can also benefit from supplementation. Then patients in critical care environments at the ICU, on other ventilators and the other machines, they can also benefit from supplements, because such patients being at the ward a day or two depletes a lot of their stores. Now, let's come to the barriers and enhancers to adherence to medical nutrition therapy. So the questions we keep asking ourselves, how are they able to, what prevents them? This is easy. To you, it has become a lifestyle because of what you know. But even some of us, we are just notice boards or signboards directing people to the good side. We rarely do what we tell them. So what is an enhancer is it's habitual to what they eat. Whenever you plan their meals based on what they already eat, so based on the dietary history you have taken, then you know that it is an enhancer for them to adhere to the MNT you have given. And oh, I think I've changed it. When it does not satisfy hunger, so when it does not satisfy hunger, it's more of a barrier. I'm sorry, this one is more of a barrier. It does not satisfy hunger, then the patient will not follow the guidelines that you are given. When the patient has a lack of willpower, that it's like a DMBO, what's left to be done of all the things? Well, let me eat whatever, what can come will come. Then the patient does not have that willpower. When it is work related, assuming you have asked the patient to eat according to specific time, and the person is a banker, a cashier, and it's a very busy branch of a bank, it will be very difficult if maybe a medical letter does not go for that patient. So work related, there are some patients we have who rarely stay in the house. So most of their meals, they buy it from outside and they go outside the house for weeks. Not that I'm going and coming back in the evening. They go out and come in weeks. So adhering to the guideline becomes a very serious stuff where they are willing, but the work is not helping them. Then being a female is also known to impact whether they will adhere to MNT or not. So what are the other things that are known to affect, or these are the barriers? Unemployment. If the patient is unemployed, then know that Oh, please let me come back to the work-related. And the work-related, if at the workplace, I know US and the other places, there are some specific work that you won't be given contract if your blood pressure is high or if your blood sugar is high. So the other side is if it is work-related and it will help to improve or give you access to your work, then they are willing to adhere. In terms of unemployment, this is linked to income level, and that is also known to also impact. In fact, those who are unemployed are known to better follow it somehow compared to those who are employed. Then the presence of comorbidities. If there are other sicknesses, diabetes, or they say that my heart is failing, the rate is low, then the person is gingered, more motivated to follow the guidelines. Then the duration of diabetes. If the patient diabetes diagnosis is, if the patient has been diagnosed less than 10 years, then it's an enhancer to adhering to the MNT, because those who have been diagnosed 10 years and above is like, what haven't we seen before? So they are like class prefects in managing diabetes. So most of them, they default in the guidelines. Or if the patient has received MNT, it's like currently at day 0 up to 3 years. So anywhere in between is also an enhancer to following MNT. What are their reasons for adhering? Those who adhere, they say that they've seen improvement in their overall health, and that is a motivator. They've known it to control their blood sugar. This is based on the research. They've known it to reduce complications, or they want to reduce the complications, and because the doctor says so. So that's where the teamwork comes in. If we are able to encourage our colleague doctors to refer and to affirm the importance of the MNT or visiting the dietitian, the patient, this is not GAND-Asiedu, this is outside. So the patient, they will take the advice of the doctor because they trust the doctor more than some of us allied workers. So in conclusion, I'll say that a lot of studies, which based on time I couldn't show here, have shown that medical nutrition therapy works not just on reducing blood sugar level, but in reducing lipid profiles, especially low density lipoprotein, and enhancing high density lipoprotein is known to reduce systolic and diastolic pressures to levels that some medications cannot even reach. So we should be confident in implementing it and use the recommendation on individual basis. Thank you.
Thank you so much. This is very insightful, deep. We've gone to the classroom to learn about everything from pharmacology to public health to diet and disease, pathophysiology, biochemistry. We are very grateful. Please, if there are any questions, you can either send them into the chat box or we can raise up our hands and ask our question. I see Sarah Labi's hand up. Sarah, you can ask your question.
Okay, thank you very much, Auntie, for that was really a detailed presentation. With the barriers to the adherence of the MNT, you mentioned being a female is a cause. I wanted you to explain that one because it's
okay. That one, there was a mix-up, but being a female is rather an enhancer. Males are known not to adhere. So based on that research, they realized that someone being a female had the likelihood of adhering to the MNT compared to being a male. I hope I've answered your question.
Yes, please, well explained. Thank you.
Okay, you're welcome. And I think practically we can bring it into our setting. Women, we cook the food. Men, if they don't come with their wives or their sisters or family members, they go and say whatever we've told them, and they think they want to or show something else because they've been diagnosed. But females, we are the ones doing the food, so we are able to understand it better. Thank you.
Okay, I have a question, Sister.
Okay.
About honey, what's your recommendation? Should we give it to our diabetics or we shouldn't give? I heard you saying something about fructose, glucose. So what's your take about honey?
Okay, so with what I found out, it said that honey has it contributes to lower glycemic response. It doesn't mean that the response doesn't come, but the response is lower. But large amounts, like 15% to 20% of daily energy, will have negative effects on plasma lipids. So not just on sugar levels, but it will have on plasma lipids, specifically on triglycerides. So that's my my take on that. But we know that with honey, there's nothing like little. If you add little, it's just makes the food more bitter. It has bitter aftertaste. But if the person can take minimum amount and being cautious that is from a good source and not infected with the E. coli that we know of or salmonella, then the person, I think, can do the exchange and take the honey.
All right. So there are so many. Let me ask some few questions here. Then we continue. It says, what is your experience with the use of herbs and alternative medicine for managing diabetes? Can that one to be a challenge? This is from Aquilina. Thank you for that. That's a question for you.
Okay, so we know herbs are able to improve the flavor of the food. Aside the flavor, it also has other phytochemicals and other nutrition related chemicals that enhances general well-being. They have very good oils, although some also, I'm combining the herbs and the seeds. Some also have more of omega-6 polyunsaturated fats, like the flax seeds, the sunflower seeds, they have more. But if we are to take varied foods, I think there will be a balance. So with the herbs, we encourage that diabetics can add to their meals. And they should really even add it. Let me give an example. I had a client who was diagnosed diabetic and as well as having high blood pressure, and was told to take Precursor, not just the Precursor. You see the four sides of the Precursor, the soft side. You cut that one off and you mash it, you dry it, and you mill it into powder form. So the patient will add just half or quarter teaspoon to their porridge. And the way their blood pressure just went so low that they had to be taken off the blood pressure medication. But you find out, is it the low blood pressure or is it sustaining? Can it be maintained? So we encourage that these spices, if they are included in the meal and not used like a concoction, it's replacing my medication the doctor has given me. That's what we discourage. But adding it to the meal, knowing that any anti-nutritional property attached to it will be counteracted by other nutrients or food items that you have used in the same meal. So there will be a balance. So we encourage herbs and other natural spices.
Okay. So there are so many applause for you here, but we'll come to that later. There's another question here. How difficult is it to ask a client, especially a male, to come with the spouse, per your experience? How difficult is it to ask?
It's not it's difficult because I think in the house the relationship is not that good, so they've gotten to a level where the wife is saying, in quotes, I can't keep myself, where I've reached, if you want to go you must go. So when you get such clients, that one is difficult to get their wives or their caregivers to come along. But you get very responsible men. In fact, their first visit, they are coming with their wives. And I've also told most of the doctors who refer to us that, if possible, tell them to come with either a caregiver, especially someone who cooks for them. If the person is the wife, fine, but at least the person will hear firsthand from us that this is what is supposed to be, and its impact on the entire family's nutritional status as well. So I think it's a journey and how you talk around it.
There were some hands up. Let me call them briefly. So
Okay.
Mariam, your hand was up. You can speak.
Yes, thank you very much. Good evening.
Good evening.
Good evening.
Yes. I want to find out, you touched on the artificial sweetness and their dangers when it comes to diabetes. But I want to find out about recently, we have a brown sugar in the market. Some of these diabetics will come and they will tell you that doctors have recommended that they take the brown sugar. So what is the role of this brown sugar in the management and control of diabetes? Thank you.
You're welcome. I've not really looked through, but I know that most of these brown sugars that we have has just been coated with molasses. And to give it color, there are some fake ones too in the markets. It's not molasses that has been used. They've used other colors to make it brown. But its impact, it will be the same as what sucrose will do, because it's coated on sucrose. So I think if we are doing exchange, we can still consider that as group them under sucrose. Just that some of them, I have not eaten some before, unfortunately, but some of them also have bitter aftertaste. So the patient is forced to take larger quantities to offset the bitterness. So that's something that we have to caution them not to. But there's no reason not to add sugar to the patient's meal if they wish.
Okay, Ivy Frempong, the hand is also raised. You can ask your question. Ivy Frempong.
Hello. Good
Hello.
evening.
Good evening.
Thanks for the presentation.
You're welcome.
And I want to make some contribution.
Okay.
Not a question as such. If I mentioned that for diabetics, they recommended for carbohydrate recommendation between 45 to 60 or something like that about the carbohydrate.
Yeah.
In practice, when you calculate based on that, you are going to get a higher value in terms of grams of carbohydrate. So sometimes when you go by that, still the patient's sugar levels are not well controlled. So like he said, what I normally do, or what normally we tell patients, is to go by the greater than the 130 grams of carbohydrate per day. That's the recommendation by American Diabetes Association. So when you do it that way, then you can have, if it's 135 grams of carbohydrate, then you can go by maybe 45 in the morning. That's a servings of grams of carbohydrates in the morning, maybe 45 in the afternoon, 45 in the evening. Another thing is that sometimes you ask the patient, people who can afford, to do before and after. Before food, they will check their sugar. After food, they will check their sugar. And also, in addition, you ask patients to write down what type of food they are taking, so that when the patient comes, patient always want to see result. When they bring the sheet to you and you explain to them about the variability, how their sugar levels were impacted by the carbohydrate that they took, they are able to maybe bring it down or increase the food based on that sheet alone, before and after measurement. Because before, if the sugar levels are 10 millimoles per liter, and then maybe they took maybe 2 slices or 3 fingers of a pim, and after 2 hours of food, the sugar levels is around 11. If you bring it to see me, I will tell you that the effect of the plantain on the sugar levels were so low. It's just 1. Then if the same thing, if the patient tests the sugar levels and is around 8, and after taking maybe 4 fingers of a pim or 3 fingers of a pim, the same a pim, and then the sugar levels are hovering around maybe 10 point something, then I will tell you that that particular patient, that the 2 fingers of a pim affected the blood. So please, measurement is so important. That before and if patients are to do the test, encourage them to do the test, and encourage them to use maybe the carb or all those things. All those things contribute to the experience-based estimation, because it's only when they weigh, they measure, they can just look at food and tell that, oh, this one is enough for me. One can add on the sugar levels or not. Thank you so much. Thank you, everybody.
Thank you, Auntie Ivy. Thank you. There's another question here. Please, what is your take on intermittent fasting and glucose control among diabetics?
Okay. Thank you. So just to add on to what Auntie Ivy said, with the carbohydrates that you calculate, let's remember that we are taking between 4 to 6 servings of vegetables from that same carbohydrate, and we are also taking the servings of fruits that we are allowing the patient to take also from that carbohydrate, and that should help us to get the skeletal pure carbohydrate we are adding to their meal. In terms of please, the question that you just asked.
Yeah, what is your take on intermittent fasting?
Intermittent fasting. Okay.
Yes,
so
please.
there are different types of intermittent fasting, where some people, they eat today, they don't eat tomorrow, alternate days fasting. Some they do 8 hours, some they do 5 hours, some, but some studies have found benefits, but we don't have long-term studies yet. So the long effects of it, but we know that those who do a day before, a day after, some have said that anecdotal research have shown that yes, research, other people have said that it has led to they going on remission. But the type of, somehow we are all doing intermittent fasting with some of our patients. Assuming you have a geriatric patient who has come to you, I'm not able to sleep in the night, so I wake up around 8 and I eat around 9. And I eat my supper around 5. That is 8-hour period. So that person is already doing intermittent fasting. You can't tell the person to wake up and eat and go and sleep back. The normal time, based on research that is known for that food can be eaten, is 2 hours after meal and after waking up. So if the person wakes up at 7 and eats at 9, there hasn't been much space between when they woke up and when they are eating. So in general, as intermittent fasting, we will need a lot of data to confirm whether diabetes can follow. But with the example that I just gave, you can't just push the person, you should come and eat around 8, you should come and eat around 7. As I said earlier, we work with what the patient is willing and is able to do. And that one we know can help. And it is also known that for those who are obese, as I mentioned, they have increased cytokines and other growth hormone release in the morning. So it is not good to give a lot of, carbohydrates in the morning for proper sugar control. So it's recommended that you give at the highest about 30 grams of carbohydrates in the morning for people who are diabetic and obese, because of that cortisol and growth hormone increased release in the morning. That's what I saw. So it's something that we have to consider. But in terms of intermittent fasting, I think that's my take. If someone has any other idea, we can share.
All right, thank you. There's another question. Please, can you elaborate more on nut tree and other nuts? Which one are recommended and why? Nut tree, you mentioned nut tree and the other nuts.
Tree nut.
Right.
The tree nut, if you read into detail, like the recommendation for the DASH diet, the dietary approach to stop hypertension, as I said, they mentioned nuts and legumes. Someone will say that if we don't get the nuts, the person can take legumes, but they all have their significant levels of different nutrients. So the tree nuts are the nuts that are harvested on the trees, and it includes our own cashew that has been made very expensive even for us here in Ghana. Then the almonds, the pecans, the walnuts, the pistachios. But know that all of these can also come with varieties like salted. And pistachio, for instance, if you are to eat it, is very salty. So although it's a tree nut and the person can get benefits, the saltiness of it is also causing another issue elsewhere. So we know the benefits of groundnut. There is benefits, but in relation to the DASH diet, as we have been taught and we have read, it's more of the tree nuts that was used to get those results that we saw.
All right. Another question. Please, after injecting insulin, do you have to wait for 30 minutes before taking your meal? That's the question someone is asking.
No, now we have different types. We have different, this one we have different types. So some, as you are eating, you can take it. Some 30 minutes before you can take it. Some, yes, during the meal time, you can take it. So it's not strict. It depends on the type of insulin that you are injecting.
All right. So that's simple and straightforward. Please, I've learned upon all these dietary interventions for diabetics and their medication, yet patients will still get the complications after some years. This is a question that the person has learned that upon all the dietary intervention and medications we give to our patients, patients still get complications after some years. How true is this? How true?
It is very true somehow, but it's possible. What helps the patient who has been through who has been living and implementing MNT is that the severity of those complications will be reduced. We know that these neurological, nephrotic issues, and they are all age-related as well. And diabetes is whatever is a start is progressive. Just that, as I said, you can either slow down the progression or you can prevent it depending on where you are starting from. So what we can do is, if the person is making MNT for diabetes a lifestyle, the person will be able to reduce the severity. The first one is to delay the onset, or maybe if it has not come at all, maybe prevent the onset. If it comes, if it is threatening to come, you will delay it. And if it comes, the severity of it will not be like someone who is just eating anyhow.
Thank you. Thank you. So there's someone concerned. It says, please, the rain interrupted the network at some point. I want to know if slides will be shared. I want to know if slides will be shared. Your slides. We all want to know.
Oh, yes. Oh, yes. We'll share the slides.
All right. So there are so many applause here. Let me see if I can mention some of them. Then we can call it an evening. Abena Setre says, great one, sister. Sheila says, very, very educating. Grace says, kudos. Justine says, detailed presentation. From Esther, great and insightful presentation. Manga says, can we provide email for your slides or your notes, please? Another says, nice presentation. Thank you, Efua. Good presentation by Hannah Boateng. Says, Paul says, great and insightful presentation. Yao V says, very educative. Helen says, I've learned a lot. Thank you. Then Daniel says, great presentation. Please, the attendance sheets to have been uploaded. You can register for your CPD points. Then Dr. Frank Hefo says, great presentation. You have Infinite Note 10 years. Says, thank you. Then Eddie says, very good in presentation. Thank you. Our own Vice President, Auntie Amda says, kudos, Audi, for insightful presentation. Lydia says, okay, I've read that one. Then can you post the link again? We'll do that very soon. Then this, I think this will be our last question. Then we can take your final remarks and we close. It says, please, what is the relationship between blood group and food intake? Relationship between blood group and food intake for diabetics and hypertensive.
Okay, so I think with the blood group, RD Prince Bedu did an extensive presentation on that a few years ago. But all that we know is it has impact on weight reduction. But the other side is it's very restrictive. It reduces one's opportunity for food diversity, of which we've already mentioned that it has a positive effects on blood sugar control. So if somebody will be restricted because they are following blood group diet, it also has a negative effect on the blood sugar. The other thing is it's basically a healthy diet, but it's more restrictive. What we know is more of genetic-based diet. So I know our colleagues in the academia, some are doing microbiome, epigenetics, and all those. So we know the impact of genes on in terms of whether we'll be sick of one condition or not, and the type of meals that we can eat to enhance or be a barrier to their work. So for blood group diet, as nutrition professionals in Ghana at the moment, we are not using that as a pattern to regulate the blood sugar of our clients. Thank you.
RDPK, your hand is up. Please, you can speak.
Okay, Ardi, thanks
Yes, sir.
for the opportunity. And now become a friend of the sector.
Thank you.
I've learned a lot. And as I said the last time, because of where I find myself, when I get the opportunity, as per the presentation that been made, I want to share certain things with you. So with your indulgence, I want to see, try and share my screen, if it's possible. I just want to show something to you.
You can.
Okay.
You can do that.
All right. Because the presentation is still on, I'm not able to do that.
Okay, let me stop my, okay.
All right.
So you can now.
Okay. Please, can you see my screen?
Yeah, we can see.
All right. So there's a phenomenon now, and per international standard, what we call novel foods, or what most Ghanaians will say novel foods, right, can be developed, and then standards are set for it. The standards are developed with the Food and Drugs Authority, Ghana Standards Authority, some CSOs are part of it, industry is part of it. So a standard, or let's say a standard, has been set for a new product that become novel now, called tomato mix. All right. And so legally, or regulatorily, the product is permissible. As far as it is safe, it is okay to be on the market. However, for us, when I take off the cap as a regulatory officer and I consider myself as a dietitian, so the product we have on the market, those who are not aware, and here I wouldn't even say those who are, excuse me to say, not like some of our great grandmothers, mothers, and I don't want to even give names, but I wouldn't even say those people. But some of us who have even gone to school, as it were, are not aware that the product we have today is not tomato paste, which would normally include salt and tomatoes. What we have now on the market, and it is in the largest quantity, is tomato mix. Like I said, it is permissible. Regulatory wise, it is permissible because it is safe. However, the concern is when we are considering diabetes and sugar becomes a problem. We only care about sugar when we are talking about fruit juices, fruit intake, sugar sweetened beverages, and then we are talking about sugar itself at table, whether it's honey, RD, if one has mentioned a lot. But now let's consider two. Tomato mix. All the tomato mix, and I want all of us who have some in your kitchen now, go and check if you have it. They range between 10 to 15% sugar as a component. Sugar itself, as in sugar as we know it. Sugar itself is a component of tomato mix. So this is something that if you are treating a diabetic patient, it's got to the point where I don't know when you should even start telling them. But if I had my own way, if they can have any other have salsa. I don't want to, highlight any brand, but any other brand that you know, and the ingredient list so says that it is tomato paste, or if they can use the raw tomatoes, please let's advise same, because we can't be dealing with sugar at table. We can't be dealing with fruit juices and other sources of sugar, and we have to also deal with this. One of the things that we often tell our patient, a simple way, so that you reduce your intake and check weight loss. You take a lot of the sauce and then you reduce the carbohydrate. If you're taking a lot of the sauce, you're going to take a lot of the, these things that are in there. Tomato paste and tomato mix is going to be, a component of that sauce or, stew, whatever we are recommending. So please let's look at this and then guide our patient, because most people are not aware. And because it is taken and it gives us the, aesthetic or organoleptic appeal that we want. So this is really on very high demand. And I'm sure most of us will have some in our homes. Thank you very much.
Thank you so much. Someone just checked his Elichem. It says, I just checked on Pomo. You are mentioning the product name. And sugar is 13%. Wow. I think this is serious, and we all need to be checking and educating our clients as such. If there are no questions, comments, additions, subtraction, we invite our DFR to give closing remarks. And since she is our coordinator, she can add any other information we need to know. Then we can end this webinar.
Thank you, RD, Danny, and thank you, Pakwesi. In fact, you are welcome to our sacrum. We have taken you from Accra. You are in sacrum now. I'm excited for what we had today, and I know we are going to have more. In fact, Friday we have another presentation on innovative complementary feeding, and a very experienced nutrition officer is going to give us that, and we'll make sure that we deliver our utmost best. And thank you so much for all of you, and with the recommendations that you send my way, I'm grateful, and I've been given the impetus to continue. please be ready to join us anytime we publish any presentation. And I know our knowledge in all that we are advertising will be improved and enhanced. And at the end of the year, we say we are better dietitians and nutrition officers than before. Thank you very much and have a good evening.
Okay, let me add something quickly before we end. Pakwesi, please, I hope you are still around.
Yes,
Somebody
please,
says,
RD, I'm
I
here.
think it's high time the association works hand in hand with the FDA. I say this because
Okay.
clients do ask these questions concerning food items on the market.
Okay.
What is your take on this one? How is the association working with FDA? Or so far there's nothing happening?
Okay. So fortunately, we have one of a very big person, very strategic person in our fold, who is part of a certain group, very big group, Technical Advisory Committee on Nutrition, and a non-FDA group of persons who are at the level of our board. They are treated as the level of our board, which means they are very, very, very highly placed. A group of non-FDA persons, they're 80 number, and one of them is one of us. Our clinical coordinator is one of them. When the association has any concern, whatever, it's easier. At least there's a point person. All right. I am also there, but when she presents something like that, you know very well that it will carry a lot of weight. But I also do my bit. Beyond that, the FDA has also established a greater link now with the outside world, especially the nutrition fraternity. So beyond the committee that I talked about, every activity that we do, we include the nutrition fraternity. So be rest assured that GAND is an instrumental part, because Professor Zotto, who is a key part of GAND, is also part of that committee. So GAND has at least I can count 2 people on that committee. All right. And like I said, we also involve other members of the nutrition fraternity beyond these 2 in our work. So indeed, when they bring concerns like that, we don't take them lightly. And we are doing our very best. Right now, there's a national project being undertaken. It's called Healthier Diets for Healthy Living. Those of us, Healthier Diets for Healthy Lives. Those who joined the SSB presentation that had Professor La, he mentioned it. That has FDA doing a very specific part of the project. We are supposed to implement a front or pack labeling. So now labeling is going to be mandatory. The FDA does not mandate anybody to put nutrition information on their label because there's no national policy. Now that is being done. Beyond that, there's going to be a restriction on food marketing. We're going to put a restriction on the marketing of some of the product. Once we are able to identify that it's unhealthy, we would restrict their marketing, that is advertising. So indeed, we are really involving. In fact, now the nutrition fraternity is a key part of our work. They are. Thank you.
All right. Thank you. There's a last question. I think after this, I won't take any question again, whether it will go to Auntie Efua or Pakwesi. Says, does cooking affect the sugar content in this tomato mix story? When we cook, does it really affect
I think the calorie will still be there. I think the calorie will still be there. It's like a caramelized sugar. The caramel still has the same sugar, just that some of the branches has been changed. So in terms of calorie that we are looking at, it will still be the same, and the absorption will still be the same. But Danny, I think today we have a Tanzanian in our midst. Who listened to us all the way from Tanzania. So let's acknowledge her.
Our friend and colleague from Tanzania, we are so grateful you joined us. We are happy. On Friday, we'll send our flyers out, and I'm sure you should join for innovative complementary feeding presentation. Thank you for joining. Thank you. So I think now we can end by saying a closing prayer. Father, we thank you so much for such an insightful presentation. We pray that God, you help us to apply what we've learned so that Mother Ghana can be safe from most of these chronic diseases. We also pray and thank you for the life of our RDA for God. You have to give her the strength to read wide, come and educate us, share experience with us. And we know God, you continually bless her, bless everything she does in the name of Jesus. We pray that God, GAND will grow, become stronger and stronger, and impact many lives in this country and beyond. In Jesus' name we pray. Amen. So thank you very much and have a lovely evening. God bless you.